Thank you for this opportunity to talk on this presentation. And all the slides have been provided by Kidney Health Australia, so I'm grateful for that. I'll try and make it as interesting as possible. It's about 60 slides, so I hope I don't put you to sleep. I'd like to respectfully acknowledge the traditional owners of the land, sea, and waterways in the Iwibara people on which this event is taking place. I would also like to acknowledge the elders, both past and present. Thanks to Rochelle Pitt from Punipima Cape York Health Council for assistance and expertise in development and review of this learning module, and Richard Bear for his assistance in the development of the learning module, and Richard Foon for his assistance also in reviewing this. So the learning aim is to provide the tools to drive the early detection of CKD in a primary care setting using optimal management of CKD with a slowing or halting of disease progression. At the end of the workshop, I hope you will be able to explain the role of the GP in preventing and detecting of CKD in primary care, correctly staging CKD using eGFR and urine albumin creatinine ratio results, and create an individualized clinical action plan for a patient with CKD. So this is just a basic definition of CKD. So CKD is defined as someone with an estimated GFR less than 60 mL per minute per 1.73 meters square that is present for at least 3 months with or without evidence of kidney damage, or evidence of kidney damage with albuminuria, hematuria after exclusion of urological causes, structural abnormalities like polycystic kidneys or other cystic diseases of the kidney, and people with a biopsy proven kidney disease even though the creatinine may be normal. This is the first question for all of you. How prevalent is CKD in Indigenous Australian adults? Any guesses? It's 1 in 5, right? What about in non-Indigenous Australian adults? What's the prevalence? So this is the disease burden in Australia. It's about more than 5 million are at risk of hypertension and diabetes, and nearly 1.3 million have stage 1 to 2 CKD, and stage 3 about 661,000, and stage 4 and 5 60,000, and when you reach dialysis or transplant, about close to 26,000. 2,670. Now, the sad thing is less than 10% of these people are aware that they have CKD, and this is very, very common in routine clinical practice when we see people who are present late, even though they have been referred early on. And most people say, I don't have any symptoms, so I don't believe that I have a CKD stage 5. So despite people being given their laboratory test results, we have struggled to get the point across in at least some of the Indigenous people that we treat. So yes, CKD is a major public health problem, and less than 10% are aware that they have the condition, and unfortunately 90% of the kidney function can be lost without any symptoms at all. And it is CKD is a major independent risk factor for cardiovascular disease. So these are the causes of kidney failure in Australia. You can see that all people aged over 18 years, easily diabetes and high blood pressure account for more than 50% of the people who have a CKD, and the rest is glomerulonephritis, polycystic kidneys, and other rarer causes. But if you go to the Indigenous population, the diabetes contributes, nearly 70%, with the hypertension contributing another 7%. That's a huge chunk of people with CKD in the Indigenous population. So CKD in the Aboriginal and the Torres Strait Islanders, they are 2.1 times as likely to have CKD compared to the rest of the population, and nearly 5 times as likely to be hospitalized with CKD, and 3.6 times are likely to die from CKD, and 5 times likely to be receiving a kidney replacement therapy. And the burden of disease is greater by 7.3 times. The incidence of kidney failure is for Indigenous peoples in remote areas is up to 20 times higher than for all Australians. And again, they are 5 times more likely to have stage 5 when compared to the non-Indigenous population. And they're diagnosed with kidney failure at a younger age. 2/3 are diagnosed when younger than 54 years, and they're more likely to die from CKD between 45 to 54 years of age. So unfortunately, they experience a very high burden of comorbid CKD, particularly diabetes and cardiovascular disease. Over one third of indigenous people have either CKD or combined CKD, diabetes, or cardiovascular disease. And among Aboriginal and Torres Strait Islanders, 56% have comorbid CKD and 6% have all three conditions, which when compared to 2% of the non-indigenous states. So we'll come to the first case study. This is Doreen. She's a 47-year-old lady who lives in a town near Keynes. She was born in a remote community and identifies as an Aboriginal. She's got three children, aged 15, 13 and 8 years, and she's worked as a health worker for the last 5 years and previously a full-time mother. So she presents with tiredness and requests a checkup. So she's gained 10 kilos in body weight in the last 5 years, and she's been a smoker since the age of 18 with a 22 pack years history. There's a family history of diabetes, no history of pregnancy-induced hypertension, preeclampsia, or gestational diabetes. Alcohol intake is minimal with no admission to the hospitals and not on any medication. So her results on initial examination, she weighed 91 kilogram and has a body mass index of 33 kilograms per meter square and a waist circumference of 110 centimeters. Blood pressure was 165 by 100 after 5 minutes rest, and fasting BGL plus was 11.5. Can I just ask, in general practice, how commonly is the BMI and the waist circumference done in routine practice? Okay, because some of the people that we see in hospitals, for some reason, they say the blood pressure also is not measured routinely. So I find it a bit perplexing that the blood pressure is not measured for a routine visit. So is Doreen at high risk of CKD? For her diagnosis of CKD, her EGFR and ACR needs to persist for at least 3 months. So the modifiable risk factors are diabetes, high blood pressure, obesity, and smoking. And the non-modifiable risk factors are over 30 years. She belongs to the Aboriginal and Torres Strait Islander. Family history of kidney failure, previous heart disease or stroke, and previous acute kidney injury. So she has hypertension, she's obese, she's a smoker, and she's over 30 years old. And we don't know if she has diabetes. So her primary risk factor that we identified so far is high blood pressure, and it can damage the small blood vessels in the kidneys. And the damaged vessels cannot filter the waste products as they normally should, and that causes damage to the kidney, and it works in a vicious circle. The damaged kidneys causes high blood pressure. Second risk factor that she has is obesity. People who are obese with a body mass index over 30 are 80% more likely to develop kidney disease, and central obesity is more common than generalized obesity. So using a waist circumference is useful, although not as powerful as diabetes or hypertension as a risk factor. Obese people are more likely to develop albumin, and losing weight may improve glycemic and blood pressure control. The other main risk factor is smoking. Smoking is certainly worsen Doreen's kidney function. Smoking is associated with kidney disease in the OS-DIEP study and increases proteinuria and accelerates loss of GFR. And as you can see, with the increase in pack years, the percentage of kidney function lost is more. One of the other major implications in people with CKD, if people continue to smoke, is that unfortunately they will not get listed for transplants because they're at high risk of malignancies post-transplant. So generally, when we work up people when they present for dialysis and when they're in the appropriate age group, we specifically ask them to make sure that they give up smoking for at least 6 months. Some people do follow it, but some people get a transplant and then take up smoking again, which is very disappointing. So should Doreen be checked for CKD? If so, what investigations do we need to do? Okay, yes, it certainly should be checked for CKD. How do we do a check for CKD is by blood test, urine test, as well as the blood pressure, and complete a kidney health check every 1 to 2 years, and is meant to be done annually for individuals with diabetes or hypertension. Now, the traditional screening test that we use for proteinuria is albumin creatinine ratio. That's a fairly easy test to do in general practice. But if the proteinuria is excessive, we generally advise a 24-hour urine protein estimation to find out how severe the proteinuria and to make decisions regarding the need for a kidney biopsy. For protein, we sometimes use protein creatinine ratio as well. It's also easily done in general practice. And it's the advantage that I find with the protein creatinine ratio, it gives a better correlation with the 24-hour protein excretion, whereas the albumin creatinine ratio is a lot more sensitive in the early stages, especially in people with diabetes. So what is GFR is a blood test for serum creatinine, and we get an automated GFR based on the CKD FP equation, and above 90 is normal in healthy adults. 60 to 90 is still within normal limits unless there is some other evidence of kidney damage. And if it is consistently less than 60, it indicates CKD. So what does an eGFR less than 60 mean? It means that people with an eGFR less than 60 have a significant high risk of heart attack or stroke, decreased survival of a heart attack, more common adverse drug reaction, slow wound healing, difficulty in achieving blood pressure goals, and difficulty in fluid control. And they certainly have increased likelihood of fractures with falls, hypoglycemia, hospitalization in the next 12 months, and heart failure. These are the recommendations for CKD detection in Aboriginal and Torres Strait Islander peoples. People aged between 18 to 29 without any risk factors for CKD is recommended as part of an annual health check. We need to screen for risk factors in general practice. All people over 30 years and people between 18 to 29 with at least one or more risk factors, then we need to be checking the urine albumin creatinine ratio, eGFR, and blood pressure. And if the initial urine ACR is positive, it has to be repeated twice at least over 3 months, preferably the first morning sample. And if the initial eGFR is less than 60, it is better to repeat within 7 days to make sure it is consistently low. And the frequency is again annually if an individual has diabetes or hypertension, and every 2 years or more if the cardiovascular risk is high. Now the CKD that the eGFR that is currently generated in all the labs is based on the EPI formula. Previously, there was a different formula called an MDRD formula, and this current formula is validated in the Aboriginal and Torres Strait Islander Australia. An initial ACR test should be repeated on a first void sample if the results are positive for CKD, and it can be done utilizing point-of-care testing in most GP surgeries. I have it, I believe. And albuminuria is present if at least 2 out of the 3 ACR tests are positive, including the initial test. And CKD is present if albuminuria persists for at least 3 months. And dipsticks are no longer recommended as a screening test because of the sensitivity and specificity is not optimal. Again, random sampling is better than not testing at all. So we come back to Doreen's results. Her creatinine is 125, eGFR is 40, which is decreased. Her urine albumin creatinine ratio is raised at 238, hemoglobin is 104, the TSAT is 10% with a ferritin of 110. The fasting blood glucose is 11.5, which is raised, and the total cholesterol is 6.7, and the blood pressure is 165 over 100. What would you like to do? Yeah. Yeah, she has got an eGFR which is less than normal, but we don't know whether it is chronic because we don't know a previous result. The previous one was normal, so it has to be abnormal for at least 3 months. So if the initial eGFR is less than 60, it's recommended that it has to be repeated within 7 days. So what's your individualized management plan? Which one would you choose? Sorry? A to E, okay. You're right. So yeah, it's really needs a multi-pronged approach because she needs lifestyle advice on smoking, nutrition, physical activity, weight, start blood pressure medication, starting cholesterol medication and medications for diabetes, and reassess in 1 month. And for Doreen, metformin was selected as first-line therapy at a reduced dose as the GFR was less around 40. The lifestyle modification, this is unfortunately something that we struggle for all patients, and the key elements are making changes in the lifestyle with regards to smoking, nutrition, alcohol, physical activity, sleep, and stress. stopping smoking, a diet to reduce BMI that is tailored to culture, faith, and metabolism, and a low salt diet and a reduction in alcohol intake and increase in physical activity. So I'm interested to know how we can help the indigenous people in terms of diet and physical activity, because that's in one area that we have struggled in the hospital setting. So that depends. For this, for this lady, I would straight away start the diabetes medication. So if you're asking someone with newly diagnosed diabetes, but no evidence of proteinuria, but has hypertension, I would straight away start medications for diabetes. And what you start depends on what other risk factors are. Generally, you would tend to start with metformin, especially if people are obese and if their kidney function is normal. But you can certainly add in other oral hypoglycemic agents and then insulin if required. In terms of increasing physical activity and making a change in the diet, I don't know if there's any special strategies that we can implement in indigenous population. Just how far are they likely to take up any group activities?
Sure, but there was some group physical activities that were being run out of the AMS, the Aboriginal service.
Okay.
But I don't know if that's third. And also one of the physios was running physical activities classes for Indigenous patients.
Okay.
Start doing it in the hospital, we can start doing it in the Aboriginal and start developing programs that really good lifestyle for everything. I think that can be done from.
So, do you get any help from a dietitian, say? Uh,
The Heart Foundation have walking groups as well, and some areas have Indigenous walking.
Okay. So, in terms of how much each modifiable risk factor makes a change in your blood pressure, so weight reduction with a recommended BMI between 18 to 24.9, you get a 4.4 millimeters of mercury of reduction in your blood pressure for every 5.1 kilogram weight loss. Sodium restriction, again, the recommendation is no more than 2 grams of sodium, and in similar effect, 4 to 7 millimeters of mercury reduction by 5 grams. And the DASH diet with fruit, veggies, low saturated and total fat, this reduction in 5.5 to 11.4 millimeters mercury for normotensives and 11.4 for hypertensives. And physical activity is again for every 30 to 60 minutes, at least 3 to 5 days, you lower the blood pressure by 5 millimeters. Alcohol consumption, no more than 2 drinks per day in men and or 1 drink per day in women. Again, you get a reduction of 3 millimeters of mercury. I can see clearly that the diet is the key thing in making the most change in the blood pressure. I don't know how it is practical to enforce that, to make a change in the diet in the indigenous people. That's it's a real hard thing that we struggle in the hospital. But in routine practice, I don't know how whether you have any special strategies to help people modify their diet. Yeah, yeah. Okay. So 1 month later, we catch up with Doreen again, and the creatinine has gone up to 145. Her EGFR has dropped to 34. Potassium has slightly gone up to 5.7. Her albumin creatinine ratio has decreased to 147. Hemoglobin is touched low at 95. And the total cholesterol is again lower at 6.1. Blood pressure has come down to 150 over 80. And the HbA1c was 7. But the fasting blood sugar was 6. Okay. So she was started on an ACE inhibitor, the ARB, and her EGFR has declined since the first visit. And you suspect this could be related to her ARB. Is this a problem?
Say no.
Okay. No, it's correct, yeah. So she is taking medications, and one of the very, very common medications that we use is the ARBs or ACE inhibitors, and it's meant to cause a reduction in the glomerular blood flow, and EGFR can decline when we start the treatment. what we aim for is, provided the reduction is less than 25% within 2 months of starting therapy, it is recommended that we continue with either the ACE or the ARBs. Combined therapy with ACE inhibitors and ARBs should be avoided, except with specialist advice. Which of the following options would you now implement? The 6 choices now. So I still don't need the referral yet. They can still continue with improving blood pressure and diabetes control, as well as a diabetes educator. One of the key thing is going to be lifestyle change and blood pressure control and diabetes. So that are the key things that need to be sorted first. So she comes back to see you 3 months after the initial visit. She's still feeling tired despite making some healthy lifestyle changes. We can go through the results. The creatinine is fairly steady now at 140. The GFR is again holding at 35 with the potassium at 5.5. So you can see that the albumin creatinine ratio has come down to 75. Hemoglobin is still a touch low at 91. The blood pressure is better at 145 over 80. The fasting blood glucose is 6. So she clearly, because GFR is currently 35, so the CKD staging would be 3B and she's got macroalbuminuria, where the urine ACR is more than 35 in females. When you have a macroalbuminuria, irrespective of the eGFR, or if you have an eGFR less than 30, irrespective of the albuminuria, then the goals of management are slightly different and more intense. So you need to find out what is the underlying cause for the kidney failure. And the key aim is to manage risk factors and reduce progression of the kidney disease and avoidance of nephrotoxic medications or volume depletion and absolute cardiovascular risk estimation. Now, early detection and management of complications is important, and then appropriate referral to a nephrologist is indicated. And obviously, most people always make adjustment in the medication doses appropriate to their kidney function. And the last stage is when they are prepared for a kidney replacement therapy if appropriate. So she also has anemia. The treatment options for anemia include IV iron and treatment with EPO. And this, I think it needs a referral to a nephrologist. But most people, I think GP practices are allowed to give injections once it is prescribed. Am I right? Okay. Yeah. Oh, so you can even give a prescription for EPO. Yeah. Yeah. Okay. Yeah. So what is the long-term prognosis and what follow-up will she require? So obviously the long-term prognosis is dependent on how we manage and achieve targets of therapy. And she obviously requires regular checks on risk factors, and including Doreen's family members in her management is important, and obviously a referral to a nephrologist based on our albuminuria. Now, we have had different members, indigenous people some people are not very keen to have their family members involved at all, whereas some people want their family members involved. So I don't know what your experience is. Yeah.
Most individuals don't.
Yeah, that's what I felt as well. Yeah, most people are not very keen on the family members getting involved, so, for various reasons. Appropriate nephrology referral is meant to reduce the rate of progression to kidney failure, decreases morbidity and mortality, as well as the need for and duration of hospitalization. Now, early referral is key, and that is particularly relevant for Mackay because we don't have an in-house vascular surgeon for AV fistula creation. We generally tend to see people in all stages of CKD and generally start giving education for renal replacement therapy when the GFR is around 30. And once the GFR is between 20 to 30, all of them get referred for a fistula if they want to go on hemo. And we refer for an AV fistula when the eGFR is less than 15. Most of the time it works, but there are people that we have struggled for various reasons. People have to go to Townsville currently for a fistula surgery. That is at the moment a problem for some of the patients. But despite all these constraints, I think we are doing quite well. More than 60% of the people who are referred to us initially, before it is too late, have an existing AV fistula at the time of onset of dialysis. So these are the general guidelines for referral to a nephrology service. eGFR less than 30, which is persistent, or persistent significant albuminuria, where an ACR is over 30, or a sustained decrease in eGFR of 25% or more, and CKD with hypertension that is hard to get to target despite at least 3 antihypertensive agents. The referral not necessary is stable eGFR over 30 and urine ACR less than 30 with controlled blood pressure. One other common referral that we see is people with simple cysts. For some reason, we get referred people with simple cysts, and we reassure patients and don't end up doing anything for these people, but that's what the GP guidelines say for people with simple cysts. The GP is obviously very crucial in sustaining ongoing relationship with the patient and their families, coordinating care provided by others, ensuring outcomes remain focused on the goals and advocating for the patient. And they're responsible for supporting and assisting patients in managing CKD, co-developing management plans for the patient and nurse, and screening for comorbidities and managing the common issues of CKD, and then psychosocial issues and health promotion and disease prevention. The Aboriginal healthcare worker, again, is crucially important in reducing the impact of CKD. And if we are able to detect CKD early enough and provide education and assess patient management and modify risk factors, generally, we would be very successful in reducing the progression of CKD, improving lifestyle choices and promoting lifestyle programs, as well as assisting in avoiding nephrotoxic drugs. So this is again a general question to people in general practice. How would you implement a system to screen Aboriginal and Torres Strait Islanders and other high-risk patients for CKD? All right.
Trying to do it at the moment.
Okay.
See what your data like.
Yeah.
And then identify those risks and do a recall.
Okay. But how do you do that, on a mass scale for people in the practice?
Through your
Uh-huh.
so you do a search for a specific algorithm,
Uh-huh.
and it identifies select people that identifies Aboriginal Torres Strait Islander. You can do within age groups those that are on medications or that have a condition, or you can actually identify patients that are that identifies Aboriginal Torres Strait Islanders that have indicated but not diagnosed,
Right.
as well, and that could be of CKD or diabetes or whatever.
But how commonly is it being done? Is it very commonly done, or?
They're engaging with their data software, but unless you know how to use it, and you need to engage a team to help you do that. So, but there's always room for improvement for everyone.
Yeah.
PHN's doing a quality improvement activity.
Yeah, so the recommendation is for people aged 18 to 29 without any risk factors, screening for risk factors as part of an annual health assessment, and people over 30 years and people between the ages of 18 to 29 with one or more risk factors. The recommended assessments are urine, ACR, eGFR, and blood pressure, and at least every 2 years or at least 12 months for individuals with diabetes or hypertension. This is not something which is familiar to me. So I'm sure most people in this group will have some idea about what the item numbers are for the GP setting. So for these items, where is the item numbers? Is there a difference in the consultation timing? There is. And how often can you do one of these numbers in a 12-month period?
The 715 is usually 9.5.
Okay.
And then you identify whether they have a chronic condition, and then they can get a 721, 723, and that's 721 is every 12 months and 1 day, and 723 as well. But the 723 is team care arrangement, adult health services or specialist help, and then you do a 722 every. You can do it up to 3 months. That's the maximum, but usually it's every 24 months.
Okay. So is there a prerequisite that you need to use these item numbers when managing your CKD population at all? Is there a prerequisite for a practice, for a general practice, that you have to use these item numbers at in a certain percentage over.
Some practices don't do care plans with the item numbers, but the item numbers identify
Yeah.
those services provided.
Okay.
So therefore, the Department of Health can identify needs for different areas.
Okay.
So then that's where they come up with health needs assessments. So it's a bit of a
Yeah, I'm nearly coming to the end. So yeah, CKD is a major public health problem that is treatable and preventable. It's much more common in the Aboriginal and Torres Strait Islander peoples, and unfortunately often goes undiagnosed. And it's important to stage CKD using EGFR and urine ACR, and obviously assessing for complications to delay progression and improving quality of life, and proactively identify patients at risk of CKD and perform a kidney health check. And I'm sure most people are familiar with these resources that the Kidney Health Australia provide, and the resource kits for Indigenous people as well. And the fourth edition handbook is can be downloaded, as well as you can buy a hard copy. And there's the CKD Go app, which is also free. But thank you very much. I hope I haven't put you to sleep.